Welcome to The Explainer. Today, we are diving into one of Australia's most intense medical emergencies, snake envenomation. This is a really high-stakes situation where knowing the right moves right away can literally be the difference between life and death. So picture this. You get that pre-hospital call. A patient's on their way, bitten by a snake, species unknown. The clock is ticking. Every decision you make in the next hour is going to define their outcome. So, do you know exactly what to do next? Let's break it down. We're going to follow the patient's entire journey, right from the moment of the bite all the way through to a safe discharge. We'll cover the culprits, the snakes themselves, then first aid, diagnosis in the ED, the huge decision to give antivenom, and how to manage what comes after. By the end, you'll have a clear framework for this emergency. First things first, let's meet the enemy. Here in Australia, there are really 5 main groups of snakes that cause the most trouble. And you've got to know that each one of their venoms leaves a pretty unique clinical signature. Okay, this table really gets to the heart of it. You can see the big 5 lined up against the syndromes they cause. Now those top 3, the brown, tiger, and tapeworm, they are notorious for causing VICC. That's venom-induced consumptive coagulopathy, a fancy way of saying the venom just obliterates your clotting factors. Some also cause kidney injury or TMA. Then you have neurotoxicity and myotoxicity. That's nerve and muscle damage. But here's where it gets interesting. Notice the differences. The death adder, it causes pure paralysis, pure neurotoxicity, and it doesn't touch the blood. And the black snake, it causes an anticoagulant effect, sure, but it's totally different from VICC. Recognizing these patterns is absolutely crucial for what you're going to do next. Right before your patient even gets close to the hospital, probably the most important intervention has already happened, or at least it should have. Good first aid out in the field is everything. It buys you precious, precious time. And the technique you need to know is pressure bandage immobilization, or PBI. It's actually a pretty simple 4-step process. You're going to start with a wide elastic bandage right at the bite site, apply firm pressure, and then just work your way up the limb. Then, and this is key, you immobilize the entire limb with a splint. The whole idea here is to slow down the lymphatic system, to stop that venom from getting into the main circulation. Now, it's just as important to know when not to use PBI. It is absolutely the standard of care for all our land snakes and for funnel web spiders. But you must not use it for sea snakes, other spiders, or fish spine injuries. In those cases, it can actually make things much worse. Okay, the scene change. Your patient is here. They're in the emergency department. PBI is on. Now the game shifts. The question is no longer just what bit them, but the much more important question, are they actually envenomated? First move, get bloods, a good baseline set. You're basically going on a hunt for clues. That coagulation panel, your INR, APTT, fibrinogen, and D-dimer, is looking for that VICC we talked about. A CK level checks for muscle breakdown, that's myotoxicity. And your FBC and a blood film can show early signs of microangiopathy. This panel gives you the first hard evidence of what's going on. Now, what about the snake venom detection kit, the SVDK? It's a useful tool, yeah, but it always comes second. Your clinical assessment of the patient in front of you is number 1. If that patient is clearly envenomated, they're bleeding, they're paralyzed, you treat them. You only use the SVDK if you've already decided to give antivenom, but you're just not sure which one to pull off the shelf. Never, ever delay treatment to wait for a kit result. And that brings us to it. The single most critical decision you're going to make for this patient. The choice to give antivenom is the turning point. It's the whole ballgame. And you know what? Sometimes the decision is made for you. These here are the absolute indications. A sudden collapse or seizure, a coagulopathy showing up in the INR, any sign of spreading paralysis. We're talking droopy eyelids, trouble swallowing, or of course, cardiovascular collapse. You see any of these? There is no debate. You give the antivenom and you give it now. But, and this is a big but, you have to remember that antivenom is a foreign protein, and the risk of an allergic reaction is surprisingly high, up to 40% of the time. It can be anything from a mild rash to full-blown anaphylaxis. What does that mean for you? It means you have adrenaline drawn up and at the bedside every single time. No exceptions. This risk also helps guide your choice of antivenom. If you know the snake, fantastic. You use a specific monovalent antivenom. It's more targeted, and it has a lower risk of reaction. But if the species is a complete mystery, you have no choice. You have to use the polyvalent, which covers the big 5, but, you guessed it, carries a much higher risk of anaphylaxis. All right, this is a massive safety point, so listen up. Once you've started the antivenom infusion, you wait. You wait a full 30 minutes before you take off that pressure bandage. Why? Because you want that antivenom circulating, ready and waiting to neutralize the big flood of venom that's about to be released from the limb. If you get this timing wrong, your patient can deteriorate fast.
So the antivenom is in, the PBI is off, you've neutralized the ongoing threat, but the battle isn't over. Now you have to manage the damage that's already been done. And the complication we all fear the most is VICC. Think of it like this. The venom acts like a super powerful procoagulant, and it just burns through every last clotting factor in the body. It completely uses them up, and what you're left with is a patient whose blood literally cannot clot, putting them at huge risk for a major bleed. And here is a classic distinction, one you absolutely have to know, especially for exams. With VICC from your Browns, Tigers, and Taipans, you'll see an undetectable fibrinogen level and a sky-high D-dimer. But with the anticoagulant effect from a black snakebite, the fibrinogen and D-dimer will be normal. So checking that fibrinogen level is the key test that tells you which one you're dealing with.
All right, we have walked through the whole chaotic process. Let's boil it all down to the most important, high-yield points that you really need to take away from this. So what about the patient who got bitten but was lucky enough to not get envenomated? Well, for them, the path to going home is pretty clear. You observe them for 12 hours. If they stay totally well, and their serial bloods, especially the coags, are completely normal at the 12-hour mark, they can be safely discharged. Just make sure you give them really clear instructions on when to come back. Okay, for your exams and for your practice, these are the facts you need to know cold. 1. The antivenom dose is the same for kids and adults. It's about neutralizing venom, not body weight. 2. Brown snakes are famous for causing an early collapse. Happens in about a third of cases. 3. Death adders give you that pure isolated paralysis. And 4. Remember the black snake's signature. A coagulopathy, yes, but with a normal fibrinogen. If there is one single principle, one rule you take away from all of this, let it be this one. Your clinical judgment is king. If the patient in front of you is clearly, obviously envenomated, you act. You act immediately. You do not wait for labs. You do not wait for a kit. You treat the patient. And one final thought to leave you with. So you've navigated the acute crisis. You've done an amazing job. But your role isn't quite finished. There's an immune response to the antivenom itself. It's called serum sickness, and it can show up 5 to 10 days later. So your discharge advice has to cover this crucial follow-up. If this explainer helped you get a better handle on this critical emergency, then make sure you subscribe for more high-yield content made for the modern clinician. Thanks so much for watching.